Thank you all for joining today. So we're going to discuss transmission risks among persons who use drugs with a focus on hepatitis C and HIV. And of course, there that will involve co-infection and some important concepts here related to the shared transmission risks between Hep C and HIV, and thereby leading to risks of co-infection. And I think this is very relevant because as we identify populations who need treatment, people who inject drugs in particular are the highest risk in terms of transmission and who account for the vast majority of new infections. HIV is somewhat different, but there's some shared risks. And so I think this will be helpful just to kind of set the stage of who we need to think about when we consider who's at risk for Hep C, for considering therapy, and who may also have risk of Hep C and HIV co-infection. So let's move on to the next slide. So here's my conflict of interest disclosure. Can move on to the next slide. And our statement on trade names. Next slide. So, as far as our objectives for today, we have three objectives. One is to identify and understand the epidemiologic trends in hepatitis C and HIV among people who inject drugs in the US. And we're going to get the most up-to-date available information. I think many of you know that when it comes to epidemiology and assessing trends, there's always a delay because it's hard to get that national level epidemiology from places like the CDC. But we have sort of the most updated, and it's important to see those trends. We're going to review the transmission risks associated with injection drug use. And we're going to discuss prevention strategies to decrease transmission among these high-risk populations. Next slide. So just as an overview for hepatitis C and HIV, these are both viruses with shared transmission risks that affect high-risk populations, but they're very different in some ways. So let's start with hepatitis C. So it's estimated based on the NHANES survey, at least 2.4 million people in the US are infected, and a significant proportion, even after the availability of direct-acting antiviral therapy and all the efforts that we've made, which have made a difference, there's still, it's estimated around 40% of people are undiagnosed. And what's interesting is there have been some studies, and on our final page of our final slide, there's some references which may be useful if you want to learn more about this. But when they account for people who inject drugs, this number goes up to over 4 million, and that's still the case. So, important thing to consider here in terms of the prevalence of hepatitis C. And coinciding with the opioid epidemic, acute hepatitis C infection increased fourfold or over fourfold from the decade 2010 to 2020. And still, it's somewhere possibly over 60,000 infections annually, as far as estimates. That may be on the decline, but we're going to talk about the high risk population that this affects. Accounts for at least 13,000 deaths per year. It's one of the major causes of death in the US. And chronic disease develops in up to 85%. So those who are exposed to hepatitis C are at risk of developing chronic disease over time. And that includes development of cirrhosis, requiring a liver transplant, developing liver cancer, and importantly, direct-acting antiviral therapy is curative. We have a cure for hepatitis C. HIV, let's transition to HIV. Smaller numbers, but the thought is over 1 million in the US are infected. And during that same period of time that I mentioned, during the opioid epidemic, There are at least seven HIV outbreaks among people who inject drugs. So this also HIV experienced a significant increase coinciding uh, with that, over 4,000 deaths per year. And importantly, disease progression will occur within 8 to 10 years if HIV is untreated. And of course, we know that leads to AIDS and opportunistic infections and high mortality. Antiretroviral therapy actually improves survival among people living with HIV. And as we think of it now, people can live with HIV on therapy as opposed to in the early years of understanding HIV a few decades ago, that corresponded with a high mortality. Now we can treat this. And importantly, we think about HIV and Hep C, co-infection with HCV among people with HIV leads to an accelerated progression of liver disease. So they develop cirrhosis faster, they develop liver cancer more frequently, they have a higher mortality. So that's why this is important when we consider co-infection. Next slide. So there's some studies that have come about recently looking at the global epidemiology of people who inject drugs, and in particular, the prevalence of Hep C and HIV in those populations. There was a fourfold increase in the prevalence of people who inject drugs over the decade around 2011 to 2018, sort of in that same decade of the opioid epidemic. It's estimated maybe 1.5% of the US population. It's over 3.7 million people. And when you look at the maps, the prevalence of HIV and the prevalence of HCV in North America, they kind of mirror each other again because that's sort of this shared exposure risk among people who inject drugs. In North America, in that population of people who inject drugs, more than half are homeless. Almost half have a history of incarceration. And importantly, I have the sort of red outline here about 40% or over 40% Hep C positive, 5.9% HIV positive. So you'll see that it's a smaller proportion have HIV among people who inject drugs, and that's related to the transmissibility of the viruses. In particular, vulnerable population currently, based on this epidemiology, people who are at risk of HCV and HIV among people who inject drugs are younger people and females. So that's a shift. And we've seen that trend, particularly with Hep C, that acute Hep C in the US, we see this now in younger age groups and in women as much as men. So we have to consider that when we think about vulnerable populations. Next slide. So this is the updated sort of assessment of exposure risk to hepatitis C. This is from the CDC. It's 2022. That's as recent as we get right now in 2025. So we're always a couple years behind. But as we've seen this pattern in the past, injection drug use remains the principal risk factor for hepatitis C transmission, over 50%. Another group are those with high risk sexual exposure, and I wanted to point out that along with men who have sex with men, we'll get into that with HIV and co-infection. These are very important groups to consider when we think about transmission risk. Next slide. For HIV, it's different. So injection drug use is a smaller proportion, 7%. Again, we'll get into the details about the transmissibility related to injection drug use, but um, among men who have sex with men, that is the largest proportion considered to have high exposure risk. So that the men who have sex with men component, that's the highest risk population for HIV exposure. And among that group, they're uniquely at risk of sexual transmission of hepatitis C. So that's an interesting focal point we'll get to as far as not just injection drug use, but what about sexual transmission of Hep C? Certainly with HIV, we're aware of that. And heterosexual contact is, another large proportion when we think about HIV exposure. Next slide. So this is the updated to 2022 estimated acute hepatitis C in the US. And I mentioned previously there was that fourfold increase in acute hepatitis C in the US from 2010 to 2020. You can see it peaking sort of around 2021. And the line here, the orange line, are the actual reported acute cases. But the CDC is able to, based on their surveillance program for acute infectious diseases, they're able to estimate what is believed to be the actual number, and that exceeds 60,000. Now, there's a trend downward for 2022. I think we're hopeful that we're going to see this begin to decline and possibly related to efforts to address the opioid epidemic. Um, but you can see here that, it's still kind of maintaining at this 60,000 cases per year as far as estimates of acute infections, at least to 2022. Next slide. And what's important here is when we look at the age groups, the green line here are people in their 30s. So this is affecting, and even during the opioid epidemic, when you look at 2010 to 2020, so right around 2018, you see this crossover where the even younger groups of individuals in their 20s were actually at the highest rate of acute infection. That has declined over the last 3 years here in this trajectory to 2022. But the 30-year-old group is still uh, seems to be rising, at least to 2022. And that's important because, historically, we used to think about hepatitis C in sort of older age groups, but as far as acute infection, acute exposure, it's younger individuals. And in particularly this, 20 to 40 age group, year old age group with possibly a decline in people in their 20s, but still relevant in the 30-year-old age group. Next slide. What's interesting is when we think about HIV infections, this is also taken from the CDC, we see a similar pattern. It's interesting that these viral infections, in terms of exposure, seem to fall together because of the shared transmission risks. So there was sort of this increase from 2020, a decline, certainly, probably from, certainly the COVID pandemic and social distancing, you can consider those the effects related to those, but then a rebound up to 2022. And interestingly, it's the same age group. Here we have this 25 to 35 age group who are the ones who are at the highest risk of acute HIV infection. Next slide. So when we think about co-infection, so what's important to understand here is that HCV, hepatitis C, is more readily transmitted than HIV through injection drug use. So with a single needle exposure, the risk of an HCV transmission is nearly 2%. Versus HIV, it's down to 0.3%. So there's about a six-fold increase in transmission within a single needle exposure. And that's why you see when you look at the co-infection sort of group here, you have this larger proportion with Hep C. These are the NHANES numbers that you're seeing here. And there's this overlap. But Hep C is more readily transmitted. So there's less sharing is needed to transmit Hep C versus HIV. And we'll talk about this in a moment, that sharing of the drug preparation equipment, not just the needles, can transmit hepatitis C. And that's an important educational component, I think, for those of us who are clinicians, when we encounter individuals who have hepatitis C, um, or HIV and have a history of injection drug use, especially if there's concerns for current injection drug use, that it's not just the needles. The equipment can also transmit hepatitis C. And so because of this increased transmissibility related to hepatitis C among people who inject drugs, the prevalence of hep C is actually higher than HIV when you look at that population. Next slide. So the likelihood of exposure increases every year that a person is injecting drugs. So, and if you follow these numbers here, what we're looking at is once a person is out to, 3 to 5 years of injection drug use, then they are experiencing, over a 50% prevalence of hepatitis C. And why there's sort of this distinction between 1995 is that HIV prevention programs, including syringe needle exchange programs and expanded methadone treatment, began in 1995. There was a concerted effort to prevent HIV. But the impact of those efforts had less of an impact on hepatitis C transmission because it's so more easily transmitted through injection drug use. Next slide. So fundamentally, the transmission of hepatitis C occurs through contact with contaminated blood. And as I mentioned, needles, syringes, but also filters, cookers, water, even surfaces can be a source of transmission. And it goes beyond that. So that's why there's a prevalence of hep C even among nasal drug users. So people who do not inject drugs, but nasal drug use, the prevalence of hepatitis C in some studies has been shown to be as high as 35%. Hep C has been found on the stems of crack pipes, so it can be transmitted beyond just injection drugs. And if we think about the higher risk groups, um, more than 1 in 3 individuals in U.S. correctional settings have hepatitis C. So that's another group with a very high prevalence, high risk of hep C exposure. Next slide. So interestingly, there are differences in needles that are used among in people who inject drugs. And so, and it's related to the transmission can be influenced by the amount of dead space, what's referred to as dead space within the syringe. And if you look at the diagram on the right side, that's sort of like an older version of a type of needle that has a larger amount of dead space. It's possible, that you can reduce transmission with the use of low dead space syringes. There was a large review, a meta-analysis looking at all the available data, and there wasn't sufficient evidence to confirm how effective it was in terms of reducing the transmission with low dead space syringes. So we can't really say that definitively from a statistical standpoint, but it's important from an educational standpoint that that actually may also make a difference in terms of transmission. Next slide. And then the possibility that Hep C can be transmitted through contact with preparation equipment. And that includes filters. And, filters can be used to remove debris and things like that are created while preparing drugs for injection. Um, People use filters from cigarettes or cotton balls, or even, sort of filters that can attach to the needles themselves. Um, Also, water, the cookers that are used, even tabletop surfaces can be a source of transmission. And so, also, there's a possibility that transmission can be reduced with sterile drug preparation equipment. Again, there's insufficient evidence to say that statistically from that analysis, but it's also important from an educational standpoint that individuals who inject drugs and are at risk of this to understand that they could be using a brand new needle, but then if they're sharing cookers, water surfaces, and filters, they could still be um, transmitting hepatitis C. Next slide. And this occurs because hepatitis C can actually survive on inanimate objects. And it's shocking to people sometimes when I've shown this slide that hepatitis C can survive on a surface or a water container up to 3 weeks, up to 2 months in a syringe. And, and people think, oh, well, we just need to heat it and it'll kill the virus. But it needs to be heated for 90 seconds and reach temperatures of 144 degrees for the virus to be at undetectable levels. So again, from an educational perspective, if you encounter people while you're in a clinical setting who inject drugs, they need to know this because many people don't. Next slide. But what does work? What are the most effective ways of preventing hepatitis C and HIV among people who inject drugs? Well, two things for sure. So, opioid agonist therapy certainly does. It leads to a 50% reduction in the risk of a primary Hep C infection and over 70% reduction in risk of reinfection and over 50% reduction in the risk of primary HIV. What about needle exchange programs? That's challenging in the state of Texas. I know, I believe San Antonio, I believe has a program. Otherwise, it's just there are some sort of legal loopholes and things like that that make it challenging from a providing needle exchange as it is in other states that have done a lot of work on this. Um, but it can significantly reduce the risk, over 70% reduction in risk of primary Hep C, over 50% reduction risk of primary HIV. And then the final thing, as far as prevention, that I wanted to mention is antiviral therapy itself is the best prevention, and it's referred to as treatment as prevention. And so treating individuals with Hep C in particular and achieving a cure, then that person is not able to reinfect someone else. We'll talk about their potential for reinfection in a moment. Next slide. So fundamentally, individuals with Hep C infection are infectious until they are treated. So just to review, how do we reduce transmission? Education. So reducing the number of contacts and the probability of transmission per contact. So that, discussions in terms of injection equipment, if available, regular testing within drug using networks, and that to identify people who are acutely infected or have chronic infection and may require antiviral therapy. And to reduce the duration that a person is infectious in antiviral therapy, to significantly decrease that risk of infection to others. Next slide. What about sexual transmission? So that always comes up. Of course, we know HIV. I showed you earlier, the vast majority of cases of HIV are transmitted through sexual transmission. In terms of hepatitis C, there's actually really no increased risk among heterosexual couples in regular relationships. There was a long-term cross-sectional study of 500 monogamous couples where one person had Hep C, the other person didn't. And they did a 15-year follow-up, and they used HCV RNA sequencing to look for concordance, to know that the actual virus that through sequencing of that particular strain of virus from one individual was transmitted to the other person. And they found the overall prevalence among partners, for the other person to develop hepatitis C was 4%. But when they did the sequencing, the concordant genotype, it was actually less than 1%. So that means 3.4% of the people that where they found positive, they actually got a different virus, probably from some other high risk exposure, um, possibly something like injection drug use or some other exposure. The maximum incidence rate was 0.07% per year, with a risk of 1 in 190,000 sexual contacts. So that makes it exceedingly rare under normal circumstances. However, I wanted to point this out, and very important, the exception in particular is HIV positive men who have sex with men, where that incidence of sexual transmission increases up to 5% per year. And that risk can be even higher among those who inject drugs and have these high risk sexual exposures, something referred to as chemsex, or anyone with current or previous sexual transmitted infections. And an important concept is PrEP, which now has become something that can be used from an HIV standpoint. It doesn't prevent Hep C. And actually, there's some literature out there to suggest that the availability of PrEP actually in this population has increased, has led to increases in Hep C transmission, because then um, individuals feel kind of protected that they're using PrEP, they're preventing HIV, and then are have more confidence or more likely to engage in higher risk exposure. Where then there's the Hep C, which there's no PrEP for hepatitis C. Um, so next slide. What about reinfection? So surprisingly, it occurs fairly infrequently, less than 10%, even in the high risk groups. There's some thoughts as to why, and one of it is if you are treating within a group of individuals who are um, people who inject drugs and have hepatitis C, you're basically, that's prevention, right? You're actually decreasing the Hep C that's being transmitted within that network of individuals. The other concept is that people are have in some ways a reason, another motivator to not um, relapse into injection drug use. And so it may be an opportunity if you encounter a person who injects drugs, and to treat their hepatitis C and cure their hepatitis C, and then educate them, knowing that you know still at risk of reinfection. They may be more likely to work through other means to prevent or to reduce their risk, or to maintain abstinence from injecting drugs. Um, but the reinfection risk, again, highest in men who have sex with men, and the incarcerated population, they have the highest risk of reinfection. Those with decreases risk, of course, opioid agonist therapy, because they're less likely to sort of re-engage in in high risk behaviors. And importantly, Hep C antibodies do not offer protection from reinfection. And it's important to continue prevention education in all follow-up visits if you are treating this population, and screening if you can, at least annually in high-risk groups, because they're exposed. Next slide. So just briefly, we're all kind of here towards the end, but Reinfection should not be used as a reason to withhold Hep C therapy among people who are injecting drugs. So, when you look at the guidelines, either the United States or in Europe, sort of globally, that active injection drug use should not be seen as a contraindication, and if even treatment should be prioritized for those high risk groups, including people who use drugs. Next slide. So, in summary, injection drug use remains the primary transmission risk factor in the US for hepatitis C. Co-infection can occur through shared transmission risks, and Hep C, importantly, is more readily transmissible through a needle exposure. Populations such as people who inject drugs and men who have sex with men have the highest risk for co-infection, and measures such as opioid agonist therapy, needle exchange programs, and of course, antiviral therapy are the most effective means of preventing HIV and Hep C co-infection and transmission among high risk groups, including people who inject drugs. I think that's the last slide. So I think we have a summary references here that may be helpful. Here's some other resources.